The next chapter deals with ophthalmology. We will limit ourselves to just a handful of conditions that every physician should be able to recognize and therefore might appear on the exam. Vignette number 1, a 1-year-old child is suspected of having strabismus. You verify that indeed the corneal reflection from a bright light in your examining room comes from different places from each of his eyes. Let me read vignette number 2. A 2-year-old child is diagnosed with a congenital cataract obstructing his vision in the right eye. Now, both of these vignettes are here because there is a phenomenon very interesting and very important that we need to be aware of. Even though we're born with 2 eyes that are working and optic nerves and optic tracts and a brain that is working, during the first 6 or 7 years of life, our brain is still developing the ability to see and interpret visual messages. And if that is interfered with, that process in those critical years, the patient may then be blind on one eye for the rest of his life because the brain on that side never learned to process images from the eye. We give the name amblyopia to this interference with the function. And so you have 2 examples here. One is a child with crossed eyes. The brain is getting 2 overlapping images of a world. The brain doesn't like that. The brain suppresses one of the 2, develops the ability to see only the other one. If this is not corrected in the first 6 or 7 years of life, that eye will be blind forever, even though it's completely normal. It's cortical blindness. The brain doesn't process images from that eye. So the answer obviously is we must correct the strabismus now so the child has an opportunity to develop the ability to see. And the same is true of a second vignette. A cataract doesn't appear like a very horrible thing, but in that age group, if that cataract doesn't let that eye send images to the brain and the brain doesn't learn to process those images, if we correct the cataract after the age of 7, it'll be too late. All right? Vignette number 3 is a very important one, and we're even going to include a picture eventually for you to look at. A young mother is visiting your office for routine medical care. She happens to have her 18-month-old baby with her, and you happen to notice that one of the pupils of the baby is white, whereas the other one is black. Now, this could be a horrible, life-threatening condition. This could be a retinoblastoma. A retinoblastoma grows very quickly, advances backward through the optic nerve into the brain and kills the patient in a matter of weeks. So these youngsters need to be seen by an ophthalmologist immediately. The other thing this could be perhaps would be a cataract, but even if it is a cataract, which is more benign, it should be dealt with. Because remember, if you leave that obstruction to vision there for the next 6 or 7 years, the brain will not learn to see from that eye. Let's now talk about issues that affect adults. A 53-year-old woman is in the ER complaining of extremely severe frontal headache and nausea. The pain started about an hour ago, shortly after she left the movies where she watched the double feature. On further questioning, she reports seeing halos around the lights in the parking lot when leaving the theater. On physical examination, the pupils are mid-dilated and do not react to light. The corneas are cloudy with a greenish hue, and the eyes feel hard as a rock. This is a variant of glaucoma called acute angle closure glaucoma. The typical type of glaucoma is completely asymptomatic. So you cannot write an examination question that deals with a more common asymptomatic type of glaucoma, but this one has a very impressive presentation. We see these typically in ladies. Often they are of oriental extraction. We see these in the evening because the pupil has been dilated for several hours, like in this case in the movies. And often, even though the source of the pain is the eye, the patient will refer to it as frontal headache, and it will have that nausea with it. And on the examination of a patient, you have all of the signs that there is a very high pressure within the anterior chamber of the eye. This is an ophthalmological emergency. An ophthalmologist needs to be consulted immediately to resolve the problem. In the meantime, I have some suggestions for you here in the notes. We can use carbonic anhydrase inhibitors, topical beta blockers, mannitol, pilocarpine, and so on. Now the next one, vignette number 5. A 32-year-old woman presents in the ER with swollen, red, hot, tender eyelids on the left eye. She has fever and leukocytosis. When prying the eyelids open, you can ascertain that her pupil is dilated and fixed, and that she has very limited motion of that left eye. Many patients might show up in an emergency room with red eyes. But the key findings in this vignette I just read are that when we pry the eyelids and we look, we realize that the pupil is dilated and fixed, and that there is very limited motion of that eye. And that means there is orbital cellulitis, pus behind the eye. This is an emergency. The ophthalmological surgeon who is consulted will probably request a CT scan to assess the extent of the orbital infection and most likely do surgical drainage. Now, vignette number 6 is in a way a repeat of a topic we talked about when we were talking about trauma, but here it is as it applies to the eye. A frantic mother reaches you on the phone reporting that her 10-year-old boy accidentally splashed Drano on his face and is screaming in pain, complaining that his right eye hurts terribly. You know, the corrosive substances that people have in their homes that might lead to accidental chemical burns are either the stuff that is kept under the sink to unplug the sink. Drano or Liquid Plumber are the brand names, which is lye. It's an alkali. Or the battery in the car, which is acid. So here we have a chemical burn. Well, the principles are exactly the same we talked about when this happened in the leg. Massive irrigation. So this lady is on the phone. You don't tell her to drive to the ER. The agent is still there doing the damage. You tell the lady to pry open the eye, put it under the running water, tap water on the bathroom, and do that for a half an hour before bringing the child to the emergency room. In the emergency room, then we will also do extensive irrigation, now with sterile saline. We will remove solid matter. We will recheck the pH from time to time to be sure there isn't a little fleck someplace. And also we will look under the eyelid, because it might not be just in the front of the eye where these things are hiding. Little flecks of the Drano could be caught under the eyelid. All right, we move to vignette number 7. A 59-year-old myopic gentleman reports seeing flashes of light at night when his eyes are closed. Further questioning reveals that he also sees floaters during the day, that they number 10 or 20, and that he also sees a cloud at the top of his visual field. You ought to be suspecting here retinal detachment. Let's talk about this for a second. The only kind of messages the retina sends to the brain are visual messages. So when something is tugging at the retina, we do not feel pain or itching. We see light. And those flashes of light the patient is describing represent that. But if that tugging is really ripping the retina, there is going to be debris in the eye. And that debris is the floaters that the patient describes. And if the patient were to say, I only see 1 or 2 of those, probably there isn't an awful lot of damage. But if a patient says, I see dozens of things, it's like a snowstorm, there are these things floating inside my eye. In that cloud the patient is talking about, that cloud at the top of his visual field, that is actually debris settling at the bottom of the eye. You might remember that we see the world upside down in the eye. The eye is like a camera, right? We see the world upside down. Then our brain straightens it out. But when the patient says, I see this dark cloud at the top, that's the dark cloud at the bottom of the eye. When you add all that up, this is a retinal detachment. And that's an emergency. So you need to immediately contact the ophthalmologist, and what they will do is use a laser to sort of spot weld the retina so it doesn't rip anymore. Vignette number 8 is another ophthalmological emergency. A 77-year-old man suddenly loses sight from the right eye. He calls you on the phone 10 minutes after the onset of the problem. He reports no other neurologic symptoms. And this is a very important line, the last one, because if a patient were on the phone saying, Doc, all of a sudden, I cannot see out of his eye and I cannot move this arm. Obviously, that is not an ophthalmological problem. That's something happening in the brain. And it would be a neurological workup that would ensue. But when the only manifestations is suddenly you don't see out of one eye, that could be central retinal artery occlusion. And this is indeed an emergency because the retina is an extension of the brain. The retina cannot survive very long without blood supply. You tell the gentleman to get driven to the ER immediately, and en route, take an aspirin tablet, breathe into a paper bag, have somebody press on his eye and release. We're hoping to have a little anticoagulation with the aspirin. We're hoping to dislodge the clot that is now occluding the entire retinal perfusion, make it advance further so it kills only a small segment instead of killing the whole retina. And the last of the vignettes, vignette number 9, a 55-year-old man is diagnosed with type 2 diabetes mellitus. On questioning about eye symptoms, he reports that sometimes after a heavy dinner, the television becomes blurry and he has to squint to see it clearly. Interestingly enough, in this vignette, it is not that business about the television that matters. Diabetics eventually learn that God gave us a built-in glucose meter in the anterior chamber of the eye, because the lens will swell when the blood sugar is very high. And so these changes in the acuity of his vision, that correlate to blood sugar level are not particularly significant. What is significant is when we diagnose type 2 diabetes, which is typically asymptomatic, you don't know how long the patient has had it. It takes roughly 20 years of diabetes to get retinal damage, but this patient may have had the disease for the last 20 years. And so whenever we diagnose type 2, an ophthalmological evaluation is part of the workup. If there are already signs of retinal involvement, the laser treatment can be very useful. Obviously, you wouldn't need to do this with a 10-year-old child you diagnosed with type 1, because he hasn't had enough time to do damage yet to the retina. So before we leave the eye, let's look at a couple of pictures. I want you to take a good look at this one. This one will not only help you do well on the exam, it may help you save a life in the future. You see there the classical white reflex from the retinoblastoma. So if you ever see a child looking like this, if you get this picture on the exam, you know the answer is retinoblastoma. Let's immediately refer the child to an ophthalmologist. And if you see these in real life in the future, well, again, you're going to be saving a life. And the next picture is also quite useful. This is a lady with periorbital cellulitis. You cannot tell that's what it is just looking at her right now, but you know that if you see a patient like this, you should pry that eye open and see the pupil and the motion of the eye. If the pupil is fixed and dilated and the patient cannot move the eye, that is orbital cellulitis, pus behind the eyeball. And that is something that is an emergency that needs to be dealt with immediately. And that is the conclusion of the ophthalmology chapter.